Please welcome to the podium the Vice President of Commercialization for the Washington Biotechnology and Biomedical Association, Christiana Della Russo.
Good afternoon, everyone. I want to thank you for joining us this year at Life Science Innovation Northwest, and thank you especially for sticking it out to the end on this lovely Friday afternoon. At this conference this year, you have likely heard the word healthcare and more discussion around delivery, payment, patient, consumer, employer than you ever have before. This is intentional and on purpose because things are changing, and this is extremely reflective of the title of this panel, Seismic Shifts in Healthcare. Are you ready? So we are thrilled to have such an esteemed panel of leaders with us today to continue to beat up this topic. I'm going to introduce them very briefly, and then I'm going to turn it over to our moderator. So going in the direction to your right, we have our moderator, Dr. Lee Huntsman, Professor of Bioengineering and President Emeritus at the University of Washington, and also the former Executive Director of the Life Sciences Discovery Fund. Dr. Helen Routh, Senior Vice President of Strategy and Innovation at Philips Healthcare. Dave Chase, Senior Vice President at WebMD, which acquired his former company, which he was co-founder and CEO of Avado. And finally, Peter Neupert, Operating Partner at Health Evolution Partners. Thank you again, and I'm going to turn it over to Lee. We'll enjoy the discussion.
Thank you, Christiana, and thank you, Helen, Dave, Peter. Looking forward to a lively conversation here. Thank you all for coming. The goal, panel, is to speak into this sense of change with simultaneous confusion, doubt, and befuddlement of all of us who would like to be innovators. How the heck do we understand the changes underway? How do we think? How do we adapt? So the plan is to march through a few questions. I'm going to ask a question. And the basic ground rules are, you can speak to the question. You can say, no, I'm going to answer my own question. You can riff off of something that another panelist said, or you can say pass, okay? So you got all those degrees of freedom as we go through these questions here. And I would encourage you, as you deal with these topics, weave in a little bit about your background that gives you the perspective that you have. In other words, your corporate or business or other kinds of perspective. Fair enough? All right. So starting with the big picture, the universal perception is that American healthcare, if not broken, is A, underperforming, and B, way too expensive. And then there's a whole litany of potential diagnoses for why that is true. Okay? There's the fact that it thinks it's market-based and it ain't really a market, and in any case, a market approach doesn't work very well in health. There is the notion that we have inculcated in America a personal value system that says that I'm entitled to whatever might benefit me and I shouldn't have to be concerned about the cost. So there's a dissociation of reality there. There is the sense that politics has been overwhelmingly influential in American healthcare, and mostly to its detriment, that it has inhibited constructive change. People who feel threatened, their first stop is Washington, D.C. to get defensive legislation instead of figuring out how to change. So there's a concern about way too much politics. There's an analysis put forth by the economists that we have a completely out of balance economic power situation where the providers, in this case both healthcare providers and insurance companies, have had a dominant economic power to the detriment of the people who are paying the bills, namely governments and employers primarily. There's the sense that we have evolved a fee-for-service structure which has rewarded doing more, not doing better, and has created a complete lack of incentive for cost control. There's a sense that the single party with the greatest influence over the most expensive part of healthcare, namely chronic care, is the consumer, patient, and by and large, consumers are disengaged. And then there's the sense that really health, wellness is a lifetime thing, and the system is completely distorted. Insurance companies think in terms of 18 to 24 months, employers think in terms of from here to retirement, and then we stick everything else on the government after that, and the consumers don't have any sense of ownership of their lifetime. So there's, by the way, if you look nationally across our healthcare system, there's huge variation in terms of cost effectiveness. So that all these diagnoses exist at the same time. Now, what do you think about this? Is it irrelevant? Is it important? Are there elements of that list that you think are going to be open to change in the near term and that therefore beget the opportunity for innovation? Helen, let's start with you.
Okay, Lee, thank you very much, and thank you for inviting me to participate in this. Maybe to go back to your initial comment, just a little piece about Philips before I respond to your question. Most people think of Philips Healthcare as an imaging company. They think of us making big iron, MR, CT, X-ray, locally ultrasound as well. But we recognize the change in healthcare, and we are changing, and in fact, we are a health and well-being company because we also have a whole consumer division that is not so well known in the US, but very well known in Europe and in Asia. And we realize the opportunity that they need to work together because, to your point, consumers are key. To answer your specific question about do I recognize these changes or these challenges, when I look at this list, I see this for the US, but actually I'm going to start by going outside your questions and saying that this is a global problem. And what we see in the US, we see in the rest of the world as well. And it's brought about because of the aging population, because of the increase in chronic disease, because of the lack of skilled professionals, and because the cost is unsustainable. We see it in the US, but if you look in Europe, because of the financial crisis partly, they also cannot manage the cost of care. You look in China, so if you think about how we have to think about innovating, in 3 or 4 years, the healthcare market in China will be the same size as the market in the US. So we need to be looking at solutions that we can solve these healthcare problems with globally. So that would be my first response to your question. I agree with these points here for the US. If we only solve for the US, are we going to be doing the right thing as innovators? Or do we need to think about how we solve these problems in a way that we can also translate into other markets?
Very nice. Dave?
I would agree with many of the points up there. I guess I'd emphasize and focus on a couple of them. I think the shift, as happened with retirement benefits from defined benefit to defined contribution, is inexorable, and I think you see increasingly CFOs and CEOs of companies recognizing that they're failing in their fiduciary responsibility to their shareholders if they don't address the healthcare problem. And while I feel in a lot of respects the employer-based healthcare system is kind of the original sin of a lot of our issues, I think a lot of the innovation that I see is coming out of that. And I could go through a litany of examples there. One would be how some major employers are recognizing that, in a typical year, 6% of their employees represent 80% of their healthcare costs because of outlier claims. So they are essentially creating a national market for high-cost procedures, whether it's transplants, neurological procedures, and so on. And through that process, every community hospital is competing with the Mayos, Virginia Masons, the Cleveland Clinics. And I can attest from my own experience going from, Cadillac Health Plan at Microsoft when I left there 10 years ago to $10,000 deductible, your behavior changes. And that's when you start to see more and more of the consumerism. And as as glacial as healthcare is in changing, it's moving faster than I ever have seen. And my career essentially started in healthcare and consulting, and did a few different roles. Left healthcare for quite a while because I like being involved in startups, and I always said healthcare is where tech startups go to die, and I didn't want to work in a startup that would die, or hopefully wouldn't. That's changed. There's a lot of, the chaos and turmoil is great for technology startup. It's worked out well for us. I see it working out for a lot of other companies, and I could give some other examples, but I think that's probably enough said for now.
Okay. Peter?
I think you've defined this problem so well, I'm going to pass. It's got to go out on the golf course or something. I mean, geez.
Come on, Peter. You started out this morning with some
No, I know.
controversial remarks. We're counting on you.
I was trying to warm the audience up a little bit. You know, it was very unsuccessful, I can tell. I need another Starbucks. Howard, are you in the room? I think Helen makes a great point that outside the U.S., they have similar problems which would have many of the same diagnoses. I think as somebody who tried to build a global health business at Microsoft, where you have political infrastructures and frameworks very different country to country about how things get paid for, what the priorities are, what the needs are. We tried to innovate on the clinical side because how you do a surgery is largely the same country to country, and physicians get trained in the same way. But once you leave that domain, it's just very different. So it's hard to think broadly across, I'm going to build one set of innovation that's going to meet a broad set of needs across the globe, outside of therapeutics. The issue inside the US, where I'm more of an expert in the last couple of years, is from a social and economic problem, health is a big problem. We can afford to spend more. As Uwe Reinhardt, who's a health economist at Wharton, likes to write many times, is, you know, at the margin, I'd rather spend more money on my health than on my third TV or my fourth car or whatever other leisure pursuit. I'm going to be willing to consume more. The issue is the value of the dollars that we get for our health care spend. The IOM, of which I was a member for a short period of time, Roundtable, most recently reported that a third of our healthcare spend is waste. So just think about that. We spend about $3 trillion a year, so $1 trillion in the United States delivers zero value. And in an economic crisis or all of the other things where access is a problem or cost is a problem, if we can't solve the value equation, we can't address the other things. Okay, well, why do we have a value equation? What are the underlying reasons that we have an economic market, health delivery, where you have really crappy outcomes, where crappy outcomes is a lot of things are waste. And that's because we don't have the right feedback loops, right? In other market-based sectors of the economy, you have feedback loops that either a supplier wins and they do a better job, or consumers vote with their feet, or people respond and the product life cycles are very short, or the iteration cycle is very short, and the right thing starts to happen through trial and error. Trial and error doesn't work so well in health, not in today's world. And when you get governments involved in setting the framework and the rules, and Medicare, I think if you looked at it recently, as estimated by Denny Cortez, who is the CEO of Mayo, Medicare sets about 1 million prices. You know they can't be right. It's impossible for a centralized agency to set price for a set of services in 1 million different ways and have it be right. And it's rigid, and it doesn't change, and it doesn't evolve. And so, you know, when you think about the conversation that we've had in this country over the last 4 years, it's largely been about access, where hopefully the exchanges and ACA and all that other kind of stuff helps improve access. But unless we solve the value equation, which is about outcomes over cost over time, we're not going to get to where we need. And I think only markets will create the environment that allow us to have the pace of change that gets us to get to the value equation. And there are lots of ways to get there, but the current conversation isn't about how do we introduce a system that's going to iterate itself to more success faster.
Well, let's pick up on that, because you said two things that I want to get you to amplify on. One is the power of market-based mechanisms to move us forward. But then earlier you said that you can't do trial and error in healthcare. But it seems like we're in a season of trial and error. We've got healthcare systems bulking up like crazy. There's M&A going on all over the place. We've got a movement to accountable care organizations, entirely new frameworks. They don't use the word capitation anymore because that's socially unacceptable, but fundamentally we're moving back toward more comprehensive and more capitated systems, at least in a few experiments. We've got a guerrilla war going on against fee-for-service, everything from arbitrary decisions by CMS and employers not to pay for certain things, a whole variety of stuff. We've got a huge movement towards wellness inside of corporations, although it's very immature. They don't much know what they mean by wellness, but nevertheless, they're focused in that way. And then we've got market segmentation experiments going on. Really stunning stuff. I mean, the Cleveland Clinic is going around the country selling themselves as the cardiac factory of America. And so split off all your cardiac cases and send them to us. And they're getting away with it. I mean, Walmart, Boeing, people like that are signing up for it. And we got other people slicing the market horizontally with primary care segmentation. So my contention is we do have trial and error going on, and I'm wondering whether you see any signs that we're going to learn from trial and error. What do you think of the experiments that are underway? Can an innovator look at those experiments and draw any inferences about where the opportunities to be constructively useful might be?
So maybe I'll take this one first again. I think I also reacted a little to the trial and error comment, because I think I see trial and error everywhere. In healthcare systems, I see trial and error in partnerships and collaborations and new ways of doing things. Of the ones you mentioned, Lee, I think the one to me that is most interesting is the consolidation. Because getting the scale of healthcare systems where you have enough patients actually to do the trial and error, so that you can go from your population base to work out what's right for an individual patient, to me is one of the places where trial and error will actually work. If I think of the example of, I'm going to go back to chronic patients again and again, because particularly in the US and in Europe, that's what's going to hurt us so much. We need to get better transitions between hospital and home. So this is an example. We need to get these chronic patients out of the hospital soon enough, but more importantly, we need to stop them going back in again if they don't need to. So there can be great device experiments going on. We can build all kinds of wearables, we can build all kinds of great sensors. That alone to use at home won't solve the problem. What you need to do is get the data all connected, although I understand I'm going to have a good discussion with Peter about data maybe later. But we need to connect the data, but we need to do behavioral change as well. You can only do this with a large enough population. I've seen some initial results out of some of these hospital-to-home programs which show significant improvements in readmission rates, up to something like 40%, on a small subset of patients. The trick is having enough patients that you can pick the 5% that cost the most when they're readmitted, to get back to your value comments, and have enough of them that you can actually prove you're generating the value, which maybe becomes your market force that you then have enough to justify the cost of the program and to change the way of care. So I would say yes, trial and error, but it's got to be at scale. So of your list of things, I would go back to consolidation.
So that's very interesting. So you would say that the scale-up forces actually are opening up important opportunities. Now, I had a veteran healthcare administrator tell me, oh, if you geeks want to help reinvent healthcare, forget the establishment. Go invent things that facilitate the development of new modes of delivery. Are those things all simultaneously true? What do you think?
Well, I mean, I think if you have the incentives in place, I think the underlying requirement is a different delivery model. And I mean, the interesting things I'm seeing are fall into that category. Primary care is a good example. Helen mentioned, finding the 5%. I mean, an organization like Iowa Health, known for dealing with the polychronic, check all the difficult box, so-called hot spotter patients. And they didn't do little tweaks on the care delivery model. They rethought it from the ground up. With that, they recognized to get it behavioral change. Turns out the doctors or even the nurses weren't the most effective. It was actually health coaches. Then a number of different things they did, including recognizing that the legacy health IT systems were optimized for the legacy model. They didn't want to have to build their own thing. They did build their own thing. Eventually, they'll be off-the-shelf market for those type of things. And the results at pretty significant scale are dramatic in terms of significantly improving outcomes, greatly reducing hospital days, while actually lowering costs. So it's, in their case, it's not been exclusively with one particular type of population, but they've made a lot of headway with unions. And you look at a lot of the labor management negotiations, they've pushed the healthcare costs on the unions, and now they're quite motivated to address that. And they often have significant spenders. So things like that. I think the other dimension to look at, you mentioned Cleveland Clinic. In my detour away from healthcare, and I worked with and interacted a lot with another local oligopoly, monopoly newspapers. And it's not polite to say, but what I hear out of health system executives today is pretty much verbatim what I heard out of newspaper execs' mouths in the late 90s. And they were worried about either the competitor across town or a frontal assault from Microsoft. That was the boogeyman of the day. And it was death by 1,000 paper cuts. It was Craigslist, eBay, Monster.com, and so on. That's what I start to see in healthcare, where you've got Cleveland Clinic slicing out primary care, and bit by bit, these non-obvious competitors that are very easy to either not notice or dismiss. That's happening today. That's where there's a lot of innovation, a lot of venture money going in there. So it's happening today. It's just not all in one place at scale.
I'm going to take the sort of, I didn't, by my comment about trial and error, you don't have a systemic progression towards better outcomes, right? There's a lot of stuff happening. In a $3 trillion market, you're going to have a lot of stuff happening. You got a lot of stakeholders, you got a lot of people who want to be disruptors, you got, everybody who wants to buy everybody to beef up before, all the stuff hits the fan. So stuff's happening. The question is, are we systematically in a framework where it's going to get us to better? Unfortunately, I'm old these days, and I've sat on a lot of these panels. And in fact, the last time I was in the Washington Convention Center, I was giving a keynote speech to the American Association of Clinical Endocrinologists. And the speech was, about, use a home meter, measure it. Don't wait for the diabetic to go into, whatever the problem is, and then show up in your office and try to do something with it. And they said, I had 20 people, this is 2008, 20 people come up to me after the speech and says, we do this already. We use Excel, we have some tech in the office doing it, we measure it, we do a better job, we make less money. Go talk to the government so we don't make less money because I can't afford to do this. Right? And so where is that? Where does that scaled up? 6 years later, it's nowhere. Everybody does a pilot. I've done a pilot with the Cleveland Clinic. I've done a pilot with New York Presbyterian. I've done a gazillion pilots. They're not scaling to where I can build a business, a sustainable business, or as an investor, I know what things I'm going to do that are going to have positive feedback loops. Right? And sure, Cleveland Clinic, $3 billion organization. I've been in their hospital. It's a great heart hospital. If I have a heart attack, I'm going to Cleveland. Because they have specialization down to, if you have a left ventricular thing, there's one working staff. And if you have a right ventricular thing, you go to the guys that do it only on the right-hand side. Their outcomes are going to be great. But now think about it from a patient point of view. Well, I don't just have a heart thing. I have a life thing. Who's going to take care of me? What about all this other stuff? That's not the way we want our care delivered. Now, for certain surgical procedures, that's great. Focus factories, Clay Christensen's right, focus factories make sense. That's not where the money is, in my opinion.
So Peter, how do we get from trial and error to a framework without the government setting?
We don't get the world without the government. There's no country in the world that does, the government's not influencing it. So on Lee's list on the first slide, politics, that's my problem. But Mark McClellan, former head of CMS, now at Brookings Institution, made it very clear, as long as people think healthcare is free, the world is screwed. Healthcare is not free. The question is, how do we pay for it? We pay for it in taxes, we pay for it in reduced benefits, we pay for it out of pocket. Now, my objective in life sometimes these days is to get people to understand healthcare is not free, and we have to couple financing and incentives with the kinds of systems that we want to have. And until consumers care, politics aren't going to fix it in any country.
Okay. We got to get after, the incentives are at the root of a lot of this, right? Both for individuals and organizations, and they're heavily controlled by politics, history, and all these things. But I'm an innovator. I want to help make the system better, okay? And it's all screwed up, but it's completely unclear just how this is going to play out. So what are my options? I can sit back and say, the uncertainty coefficient is so high, and the anxiety level is enormous. The most likely thing in healthcare for the next little while is paralysis, demonization of technology anyway. So I should hunker down. That's one of my options. Another option is to say, for all the kerfuffle, hey, glacial is the right adjective. It ain't going to change very fast. I'm going to stick with business as usual until I see signs otherwise. Another option would be to say, hey, boy, the pressure on cost is coming, and there's a sweet spot just going in and helping healthcare providers run their businesses better. They've never been able to even count cost very well, let alone control it. I can help them, and so there's a niche there in everything from analytics to workflow. Another option is to say, clearly one part of the future is going to be disruptive models, like you're talking about, Dave, and so I'm going to go after that sub-market just because I want my innovation to succeed. Another option is to back up and say, wait. This is like baseball. Sooner or later, you got to swing for the fences. I'm gonna go after big problems. I'm gonna go after that wearable dialysis unit that can completely invert the dialysis industry, which is many billions of dollars and completely below the radar. Or I'm going to go after, immunotherapy because it's clear that that's going to, and go for the home runs. So if I'm an innovator, is it clear what I do in this very confusing, foggy state of things? It's really hard to predict my markets. What would I do?
I'll let one of the gentlemen go first this time.
Sure. Well, welcome to being a startup. You only have opportunity when there's ambiguity. If everybody knew how the future was going to unfold, the established guys would be doing it. So you have to make some bets. And I will readily confess I'm a congenital optimist. But I think grounded in some evidence, I think that the shift towards value is an inexorable march. And then the challenge is finding out where is that happening. And as a startup, you don't need to go after 100% of the market. You get a little toehold somewhere, and you can build off of that, and you have a model that can maybe scale into other areas. A recent example of something that's gotten some funding that I think is a pretty smart approach is Omada Health, focusing on diabetes. And they recently got, I think, something like another $23 million from Andreessen Horowitz and some others. And one of the smart things I think they did was they not only went to employers, the purchaser, the ultimate purchaser in a lot of cases, and recognizing that they have a decision process that's not as painfully long as most health systems. However, a subset of their employer customers are providers, because they have obviously a lot of employees themselves, and some of the forward-looking ones are like, hey, let's try this out in our own environment. You have some good solid evidence base, and they built their model around a diabetes prevention protocol that's got solid evidence. So I think those type of things lend opportunity, and it's a blend of technologies they're doing, but by bypassing kind of the regular insurance model to the employers, they kind of shortcut that process. And I mean, there's examples in other areas, even within Medicare, with whether it's called capitation or not, some of the Medicare Advantage programs are essentially operating in a capitated model and are doing some innovative things that we can speak to later.
So the Chase hypothesis, if I understand you right, is don't be dissuaded by the lack of clarity. That's what entrepreneurship is all about. Bet on the move towards a focus on cost, because that's going to be a ubiquitous feature. And then get to know your niche market really well. Is that a fair summary of what you just told me to do?
Very close. I would just say value over cost, because value could be better
Right.
outcome,
Okay.
not just
Fair
cost.
enough.
Yep.
Fair enough.
There's lots of opportunity to take advantage of both the short-term set of changes that are occurring while you play the chess game of what are the long-term outcomes, where are we going to likely end up long-term, right? And I think it's important always to sort of keep those two, you got to play chess at multiple levels if you're going to be a healthcare investor, because the time frame for your investment to pay off is much longer than the time frame if you're a social media company or an enterprise software company or some other thing, right? So you can't play in the normal 3 to 5 year time horizon. You've got to play in the 7 to 10 year time horizon. And there's going to be 1 or 2 elections in a 7 to 10 year time horizon, whether you're in the UK or in the US, and that creates some big change, and you have to anticipate that. If I could live in a perfect world, I'd go invent a drug. That's the best model, or a diagnostic device, best model, because you're going to save costs. There's a fairly well-defined means to get it approved and get it coded and to get it reimbursed, although some people might argue about the reimbursed component of it, and you go make a boatload of money. It works. Just all of us aren't smart enough to go be able to figure out how to find that drug or get enough capital to do it or to build that med device. So for the rest of us that have to think about it in a technology-enabled services point of view, what the hell do we do? That's a harder problem. And I've got a lot of scars from having been directionally correct, but off by 10 years, both in tech and in health. And so that 10 years from an investor point of view is a lifetime, and it's 5 rounds of capital, and it's getting squeezed, we can all go through that. And so what are the opportunities in, and I'd go to services. I mean, as we've all described, where all the low-hanging fruit is, be smarter about how you deliver services. Don't use a doc when you don't need to. Anticipate the problem before they come into the office, all that kind of stuff. And how do you do that? And that's just a very different model. It's a different investor who wants to be in services. It's a different organization. It's a different mindset. How do you get the physician leadership? How do you go get the population? I've seen lots of great ideas. Now, how do I go get a population to go after? But that's where I would go. And that's what, just for interest, Farzad, who was ONC director, he's decided, I'm going to go lead a physician-led ACO or a group of consultants to go do physician-led ACOs, because that's a service delivery model that I can use to transform health delivery.
So I'd like to build on both of those, as the dinosaur sitting on the panel here, as the big device company, right? I could be the one that might answer to one of your first 2 points of, I think I'll wait and see. I would say there is no more important time to innovate for any of us and we have to get things to market much, much quicker than we ever have in the past. But back to the challenges, two gentlemen on my left have stated, how are we going to do that? So from my viewpoint, it's not about how do I do it, which piece do I choose. How do I choose to innovate in such a way that I can plug in to the innovations in services or in other areas? So to me, in the end, it's all going to be about partnerships. So one example, I make X-ray equipment, MRs, CTs. Where does that play in changing outcomes? Well, think about minimally invasive procedures and think about image-guided intervention. I could invest from my deep pockets, probably in this room I appear to have deep pockets, in going and building devices for image-guided intervention. Why would I build them myself? Why not go find the right partners and work out what it is that I need to change in my imaging equipment that makes the interaction with those devices much better? Work out what it is that I need to change so the data that comes from those devices, the data that comes from the EMR, much as we may hate it, we can use patient history to set up the right workflow and together build the services. And then you talk about business models. I have my favorite example on changing business models with services. If I do a minimally invasive hip replacement, what about in the end that the business model is such that I as a patient only pay on the degree of my former mobility I got back? To get there, I won't do it as the big dinosaur in the room, but I will do it if I start to work more closely with the smaller companies, with the service companies, by incorporating all the data. And that's my advice on innovation, is yes, faster and together.
Faster and together. Now, but if I heard your approach right, it resonates with what Dave was talking about, which is value. Don't just concentrate on cost. Don't figure out how to make my MR machines cheaper necessarily, but figure out how to make imaging of more value to the totality of clinical care. Am I hearing you right?
Correct. And that means you have to have a way of measuring what those outcome improvements are. And they need to be clinical outcome improvements. Can I walk as well after I have my hip replacement? But they also need to be business outcome improvements for all the business stakeholders that are in there. So for my MR, it may be about more Teslas, but only if that solves the clinical and the business outcome. It may be lower cost, but only if it solves and improves the clinical and business outcome.
Value is being defined as outcomes divided by cost.
Over time.
Over time. And the engineer in me wants to say that's a way to create a new variable out of two things we can't measure. But we're going to get better at measuring these things, is that right?
I would even come back to trial and error in working out how we measure. Because the physicist is even less comfortable with that equation than the engineer.
But we're doing it all the time, right?
Yeah.
Right. So a proxy for value is price.
Yeah, good point.
Right. And price, 99% of us in this room don't know what we pay, and 75% of the physicians don't know what they charge. And oh, by the way, they charge different people for the same thing, not based on any different segmentation, but based on who the payer is, which is just ludicrous and crazy, right? And I would add one thing to what Helen was saying, which is, and I think that's both the device guys and the therapeutic guys have to think about bundling the information value of their instrument or therapeutic with a set of services. And their challenge is, how do they get paid for it? One way to get paid for it is by taking total risk. Another way to get paid for it in a world where things are coded is to try to figure out, is there enough value there to get somebody to reimburse me for that incremental value? That's a much harder problem. So you're going to have to go at risk, which puts you in competition with some of your customers. And that gets to be the hard problem for the existing stakeholders.
But we actually already see cases where our customers are willing to risk share with us. And more, that's where we're going, because that's the only way you get the collaboration. Yeah.
Well, let's just put one more take. I like where this is going, but there's another party in the innovation ecosystem, that's investors. So how do you think investors are perceiving this whole innovation ecosystem these days? Where are they seeing opportunities? Or, well, let's put a point on it. If I give you $1 billion for healthcare innovation, what would you do with it? Would you park it until there was more clarity? Would you choose one of these niches like delivery models or something else? Or Peter says that in this climate, one almost sure sweet spot is services and delivery. Would you invest in home run plays? What would you do how do you think investors are thinking, or how would you advise investors?
So from my side, I see people investing in healthcare a lot, and I see it not just the investing new, but last week Medtronic acquiring Covidien. There's lots of movement in healthcare right now. But the interesting thing is the definition of healthcare is much broader than it's ever been before, and that's where I see most of the investment. So whether you call it digital health, it's services, but it's also moving into the more consumer health realm. Whether it's listening to the reports of Samsung and Apple in the last few weeks about what they're investing in for digital health or for the platforms, the money is there. My billion, I would put on the pieces that enable the collaboration. So yes, is it services? Yes, is it a digital platform? But you can't do that without the core technical and clinical depth as well. So it sounds like the sitting on the fence answer, but my push in this is the collaboration amongst all the pieces is the only way that will solve the problem. So I would put it across the three.
And if I could just jump in on that, sorry, Dave, is as a guy who tried to build a software platform to do just what you described, it's the wrong, you can't push that rope up the hill. You have to start with the services and say, I'm going to go deliver this and get commitment to it. Now go build the right technology. And so I believe that it has to be a services-led. So for my $1 billion, I'm going over to England and buy a commissioning trust that allows me to have control of how I'm going to pay the hospital. I'm going to go rally a bunch of primary care physicians to my technology platform and make a boatload of money.
Well, and just, I would agree with that, and just to amplify that a bit, I mean, J&J, their pharma division, you know, they talk about a couple different things they've got going on. That one, they had a medication that got rejected, that they went back and basically got agreement to get payment when they could prove outcome. So they're sort of stepping into that world, and maybe, you know, Peter's probably more knowledgeable on some of the specifics there. And then in Germany, there's a particular, you know, I think the equivalent of a state in Germany where they're handling over a 10-year contract all the outpatient responsibilities for the schizophrenia population. So they are taking that risk on. Now they've got a medication in that area, but it's a lot more than the medication. And that's an opportunity for them to really dive deep in that. And there's, of course, a lot of complications, as Peter was alluding to, in that. But I think it's a pretty bold step. And I think the other area that there's an opportunity that I think is particularly relevant for this audience is where the, you know, where some of the, you know, it's traditionally been in device and life science area, and where that marries with the information technology. I think these things, you know, these worlds have been very apart. I think you'll see, you know, to oversimplify it, you know, just as there were MP3 players before the iPod, you know, this kind of more complete experience, and where you can make sense out of the data, and where there's partnerships. I think there needs to be a lot of collaboration and partnership there. You know, we're in the midst of one with that predated the acquisition of my company, but with a major medical device company in the implantable space, and they realized they need to get much closer to their ultimate customer, their patient. I mean, talk about an intimate product relationship. That's important for them to get the value during their life of that, but also when it comes time to replace that, if they have a stronger relationship and it's been a positive experience, they feel like they needed to partner with a company like ours to have that kind of tight feedback loop.
All right, I'm hearing some optimism in the middle of all this reality. How about you out there? You got any words of wisdom or nice, sharp, pointed questions? There's Don. Go for it, Don.
This might not be a question. Maybe I'd follow up on something Peter said earlier. Clay Christensen famously wrote a book about the innovator's dilemma. And in that book, he kind of outlined what happens to industries when they reach the point that healthcare has now reached in our world. Kind of an apex industry where all the tech solutions are good, and most innovation at that point is what he calls sustaining innovation. It's trying to make the next greatest advance with a higher price tag, more complex, more expensive, and that is what I see in the healthcare world right now. And in his treatise on that, he pointed out that almost all industries, when they reach that apex, are disrupted by an entrant with what he calls disruptive innovation. And the hallmark of disruptive innovation is something that is simpler and cheaper and makes no financial sense to the current big stakeholders. And that perspective serves, from my point of view, that's exactly where healthcare is right now. And I'm curious for any of your responses to what, does that make sense to you? And how can we all be thinking about what the disruptive entrants are really going to be here?
I think it's really good. Clay wrote another book called The Innovator's Prescription, which I urge everybody to read. It's very useful. The key about the disruptor is he figures out what job people want to get done at a different point. And after my talk at Lee's last seminar earlier this month, one of my employees wrote a blog post on this, is that one of the problems about not having a market is we don't have consumers to understand what job they want to have done differently, right? So it's very hard to understand how that low-end disruptor comes in place in a world where you have employers being the payer, insurers, and the government, right? And so in the consumer world, as you see here with Q-Liance and some others, at primary care or med-surg centers or other stuff, you see some disruptors there that have decided that cost and accessibility and convenience, minute clinics, are a disruptive thing. But my point is that doesn't change the system as a whole, right? And I think if you looked at the supply side, pharma and some of the med tech, you're entirely right. When you think about the delivery side, I'm not sure you're entirely right, but it gets too coupled with the finance side.
So I know we're running short on time, but just a quick hit on that. There's a few geographies that are basically getting a group of employers together with the goal of collecting greater than $1 billion of healthcare spend to basically create kind of a health marketplace 2.0 to address that issue of you need to create a new market space. And largely the employers are saying, we don't really like what we've been buying over here. We want to buy this. Incumbent guys, if you want to supply that, that's great, but we're also going to invite in some of these new models. If they pull that off, I mean, that could ripple through, and I think will be interesting to watch, and was actually kind of kicked off by a Clay Christensen keynote of all things.
We've unfortunately gone a little long. We're going to have to wrap up. I wish I could hear from the rest of our questioners. But Helen, you've come the greatest distance. Therefore, by definition, you have the greatest wisdom. Give us a parting comment.
My parting comment to this room is it's even more important to keep innovating in this environment. If you take one thing away, take away that partnership and collaboration is the only way we will solve the problem. So it doesn't mean that everybody has to do everything. We need people to focus. We need people to be focusing on services. We need people to be focusing on solving this data problem. We need people to be looking at how we do eradicate some of these diseases or significantly change therapies. But as you do it in such a way that you can make those connections and those partnerships with all the other parts of innovation. And that's the way, whatever disruption it is that comes, that's the way that we'll solve it. That would be my parting.
Thank you very much. Please help me thank our panel. And for the last time this year, our President, Chris Rivera.
Thank you. Thank you, Lee. Thank you, all the panelists. Again, I think you can see how relevant this topic is and how, as an organization, we're trying to stay ahead and get ahead of it and, again, position Washington State as a leader in this area as far as helping the healthcare dilemma that we all are looking at right now.